Welcome to the recording of this special presentation originally given at ATC 2022 as part of a Satellite Symposium. Doctors Garuav Gupta and Dr. Adnan Khan presented case studies showcasing their experience with Eurofins Virocor's Insight T-cell immunity testing.
Good afternoon, everybody. So I'm going to change track and talk about viruses, SARS-CoV-2 to be specific. So this is, instead of a case, I'm going to present a case series with one small case in the middle. We are presenting this data later on at ATC. My colleague, Johanna Christensen, is presenting in a couple more days from now. So we looked at the responses to the SARS-CoV-2 vaccine, the mRNA vaccines, with regards to T and B cell responses in a small cohort of patients with kidney transplants and belatacept. Disclosures. So again, I think as most of the audience knows that patients with kidney transplants do have a higher risk of morbidity as well as mortality with regards to the COVID infection. And we've, in our experience, and as well as confirmed from published data, patients on belatacept seem to fare worse with these infections. In addition, it's also known that with the two-dose mRNA vaccine series, patients with belatacept on board seem to have a much poor response compared to patients on traditional immunosuppression. And the response rates, at least for the humoral immunity for spike IgG formation, has been between 5 to 10%. For T-cell responses, it's been no higher than 20%. And in this context, we were seeing a higher rate of infections when the two-dose vaccine series was standard, and that's when we developed the study. Oops. Oh, that went away. I see. Sorry about that. So this is the study we had. It's a total of 12 patients who had already received the Pfizer or the Moderna two-dose vaccine series. And what we did was we enrolled these patients who were on belatacept, and we did spike IG, which was an in-house test, and the Insight T-cell immunity panel for COVID, which at the current time is a research-based test from Eurofins Virocor. And we drew the test at the time of the third dose administration, and we repeated the test after 4 weeks of the third dose with regards to both spike IgG as well as the T-cell immunity. Just a very brief word on how this assay is performed. I'm not a laboratory person, so I can't give you a lot of details, but very briefly, what's done at our level is whole blood is drawn from the patient, typically 10 cc's, and then it's shipped to the lab where the cells, the T and B cells, are then stimulated by the Staphylococcus enterotoxin B, and it apparently is a monovalent T-cell mitogen that stimulates cytolytic T lymphocytes. And you're adding viral antigens, typically spike, as well as nucleocapsid peptides from the SARS-CoV-2 virus, and there's unstimulated controls in the assay. So over incubation, subsequently, these cells are recovered, and then they're analyzed by flow cytometry, and the results are then outputted to the clinician. So these are the results of the study. With the two-dose vaccine series, only 2 of the 12 patients had an IgG seroconversion. With regards to the T-cell immunity assay, 6, near half of the patients had some evidence of T-cell immunity with the two-dose vaccine series. With the third dose of those 6 patients who had T-cell immunity, 2 more additional patients developed a seroconversion with IgG formation. So all of the patients who had T-cell immunity, of those 6, 2 had IgG with 2 doses, and another additional 2 had IgG formation after the third dose. So it's encouraging with regards to the fact that there is some response to the vaccine in these patients, but it remains subpar. And that has resulted in some change in our protocols, which I'll share with you in the next couple slides. The other point I want to make about this is that we noted that patients who had been on belatacept for a much longer duration, on an average 6 years, compared to those who had been on lesser durations, on an average 3 years, patients with longer durations had less response to the vaccine, which may not be surprising. So to take one such case very briefly, this was a 35-year-old Caucasian male. He was 7 years post-transplant. He had been on belatacept for around 3 years. This was done as part of the BMS trial, which was published in JASN last year. He had normal kidney function. He had received the 2-dose vaccine series before. He did not have any spike IgG formation with that dose, but he did have detectable T-cell immunity. With a third dose, you can now see that his spike IgG is substantially positive, and the T-cell mediated immunity remains persistent also and sustained. So again, this was a good case for us to learn from, that there are patients who may respond to the third dose and can have sustained T-cell immunity. So with regards to the next steps with regards to the study, the test findings, I'm sorry, it looks kind of blurry, but what it shows is on the left are the results for different nucleic acid proteins and spike proteins and CD4 or CD8 cells. On the right is the reference values. On the left are the values for the patient, and they're all above the reference, which indicates a positive response. You can see this a little better here with the second test. Once again, you can see that the values are above reference, indicating at the bottom a T-cell immunity response to SARS-CoV-2 vaccine for this patient. So we've kind of taken these into consideration now with what we are doing. We are prioritizing patients on belatacept to get prophylactic long-acting monoclonal antibody. Evishield is the one that's being used. We continue to encourage 4th and 5th doses for these patients, although it's questionable whether they respond at all to these vaccines or not. We have very early and aggressive treatment protocols for these patients with Paxlovid or with new monoclonals like bebtelovimab. And then we are now also doing a trial to convert patients on belatacept once a month to every 2 months, similar to the Emory paper that was published last year. I think with that, I'll stop. Thank you for your attention.
Hello. I'd like to start by thanking Eurofin for getting us all together again. My presentation is about a challenging clinical case that we had with CMV. We'll get ahead. These are my disclosures. So what we have here is a 68-year-old male patient with history of CKD stage 5, secondary to diabetic kidney disease, who received a deceased donor kidney transplant with immediate graft function and downtrending serum creatinine. The recipient characteristics were CKD stage 5, secondary to diabetic kidney disease. Calculated PRA was 0%, CMV was IgG negative for recipient, and EBV was IgG positive. Donor characteristics were KDPI of 67%, CMV IgG positive, and EBV IgG positive. Immunosuppression, per center protocol, we started with induction of ATG 3 mg per kilo plus steroids per center protocol. Maintenance immunosuppression was decided to be tacrolimus, mycophenolate, and prednisone. Patient was identified as a candidate for steroid-free regimen per center's protocol. Opportunistic infection prophylaxis per center protocol. CMV was donor positive, recipient negative. We went with valganciclovir for 6 months, renal dosing, and then for PJP and toxo, donor negative, recipient negative, dapsone for 3 months was decided as the patient was sulfa-allergic. Post-transplant course was significant because the patient had significant challenges with blood pressure and blood sugar control. Creatinine kept fluctuating from 1.7 to 2.4 after reaching a nadir of 1.4. And then at week 2, he ended up having significant complaints of tremors, insomnia that kept persisting. And then we realized that this gentleman was a rapid metabolizer with getting a high tacrolimus peak of more than 60 at 1.5 hours and a 12-hour trough of 10.4. Yes, we are one of the centers that still does peak. So shout out to Dr. Bob Steiner for continuing that legacy. Week 7, continues to have tremors, nausea. Soon after taking tacrolimus, and insomnia was not getting better. At that point, we discussed other alternative regimens, and then the patient decided to opt for belatacept-based regimen. Again, we checked the DSA, we did a cell-free DNA, which was less than 0.12%. At that point, at week 11, the patient was switched over to belatacept. Our dosing again, our protocol was 5 mg per kilo times 2, every 2 weeks times 5 doses, followed by every 4 weeks. Subsequently, week 16, patient ended up with an NSTEMI, had a drug-eluting stent placed, nothing to do with belatacept. And then the patient was obviously high-risk patient for cardiac disease. At about week 35, we stopped our ganciclovir for prophylaxis. Immunosuppression at that point was belatacept 5 mg per kilo every 4 weeks, mycophenolate sodium at 360 milligrams twice a day. The lower dose was chosen due to GI side effects and patient not tolerating the higher dose. Prednisone was kept at 5 milligrams daily. We had opted for steroid-free, but then prednisone ended up being reinstituted at some point of time. So I guess we got the weeks mixed up here, but at about week 32, we ended up, the patient had a CMV DNA PCR, which was positive at about 15,000. There was a question about actual veracity of the test because from 0, suddenly we had a 15,000. Everybody doubted the test. We did a repeat subsequently in about a week or so, and that was confirmed. So by about week 34, the patient got admitted, ended up with extreme fatigue, weakness, some diarrhea, pain over the transplant site. We had a CMV DNA PCR that peaked at about 225,000. Patient was started on intravenous ganciclovir 5 mg per kilo every 12 hours, treated for a week with a decrease in CMV counts from 225,000 to 35,000. So pretty good response that we have seen. Then at about week 35, the patient was then switched to valganciclovir. Transplant ID recommendations at that point were treatment dosing for 2 weeks minimum, then until clinical resolution of disease and eradication of CMV DNA following. And then when it goes to below a specific threshold of less than 35, which is the lower limit of quantification for all lab, on 2 successive measures, we would go over to secondary prophylactic dosing. At week 37, what happened is we went with the CMV DNA PCR, continued to be less than 35. Patient was switched over to prophylactic dosing, and the plan was to continue at about 3 months. At about week 58, we actually checked off a T-cell immunity panel, and there's a big gap here. It's more than the 12 weeks that was planned. The reason is, as we were getting ready to stop the secondary prophylaxis, the CMV counts then went back up to close to 500, and then everybody got nervous, and then we continued the secondary prophylaxis. Our first test for the CMV T-cell immunity panel showed a pretty poor CD4 response of 0.09, and then we had an adequate CD8 response. Moving forward, this is what happened. It's difficult to know because, we've gone up to 225,000 on the peak, so the small blip that we did see is pointed by those arrows. And then at week 60, we still had valganciclovir continued at prophylactic dosing because of the inadequate CD4 response that we had. And then at about week 68, this was still, CMV was less than 35. The patient was still on prophylactic dosing. At that point, we were getting nervous. We wanted to get rid of the valganciclovir. We didn't want to develop resistance. The CMV was not detectable. Or less than the lower limit of quantification. The CMV T-cell immunity panel or the INSIGHT test was rechecked again. There was a better response at about 0.14, this time on the CD4 CMV interferon gamma with the CMV interferon gamma cells. The CD8 response was still robust. And I think this goes along with an infection that was treated pretty well. At about week 78, the patient was smart enough. The patient actually stopped their valganciclovir themselves, and we actually took a leap of faith and then did not restart the valganciclovir based on the second CMV T-cell immunity assay. So for this case study, we utilized a CMV T-cell immunity assay slightly differently. What we did is we used it to determine when to end a secondary prophylaxis. All right. So I think the recommended use scenarios for the CMV T-cell immunity panel would be at the end of primary prophylaxis to determine if extended prophylaxis is needed or monitoring is needed. The second scenario would be at the end of treatment of CMV infection to support need for secondary prophylaxis, or in patients with asymptomatic CMV DNA to determine if treatment with antiviral agents is indicated. So I basically conclude my presentation here with a picture here, just to remind that next year we are at San Diego for our ATC.
Clapping for all that.